Oh. Oh. And I've got a testimony for you today.
All right, so good afternoon, everyone. And today we're going to continue with bones, but this time focusing on the human skeleton. Previous discussion, we talked about development of bones, types of bones known to anatomy. We also looked at the types of development of bones. We said there are two types. That is endochondral, that is bone developing from cartilage. As you may be aware, a fetus doesn't have bones. Fetus has cartilage after birth or at 8 weeks. So at 8 weeks of gestation, the cartilage that makes up the skeleton of a fetus begins to be transformed into bone. And that process continues after birth. So now we're going to focus on the human skeleton in its entirety, starting with the upper limbs. All right. Before I go any further, I would like you to know that the human skeleton is divided into two portions. We discussed part of this when we are looking at, body cavities and so on and so forth. All right. So we have two divisions of the skeleton. We have what we call the axial skeleton. We also have what we call the appendicular skeleton. So axial skeleton involves the following: the cranium, which is a skull, the vertebral bones. Vertebral bones run vertically from the neck all the way to the coccyx, or what you can call the tail. In addition to that, the axial skeleton also involves the rib cage, or what you can call the thoracic cage. All right. Then what is attached to those parts I've mentioned is what we call the appendicular, more like appendages. So we have a central part, which is axial, skull or cranium, vertebral bone, all the way to the coccyx. Then what is attached to that now is what we call the appendicular skeleton. So you see that the appendicular skeleton is similar in one way or the other. The appendicular skeleton involves the two parts: the upper limbs, which involves the clavicle or collarbone. Okay, as you can see here, this is a collarbone or clavicle. In Latin, clavicle means key. So whoever was naming this was likening the shape of this bone to a key. This is a collarbone. Number two is the scapula. So you have this bone here, which is the scapula. All right. Or what you can call the shoulder. Okay, now these two, clavicle and scapula, form what we call the shoulder girdle. We also have a similar girdle in the lower limb, what we call the pelvic girdle. So this is the upper or the shoulder girdle. Attached to the shoulder girdle is the humerus, forming the arm. So this part of the body is the arm. Attached to the arm, so we're going now distal. So this is now the forearm. In the forearm, we find two bones. So in the arm is just one bone, which is humerus. In the forearm, we have two bones. One is in line with the thumb, that is the thumb, that is a radius bone. The other one is in line with the little finger. So we call this as the ulna. All right, ulna, radius. Then, as we go away from the radius, or from the forearm, we go into an area of the upper arm known as the wrist, or what you can call the carpus. This is a carpus, this is arm, or what you can call the brachium. Brachium or arm, antebrachium or forearm. Then this is the wrist or carpus. Okay, that is a carpus. All right, now, in the carpus, we have carpal bones, 8 of them in total. So they are arranged in 2 rows. One row is proximal to the radius and ulna. The other row is distal to the radius and ulna. So there are 2 rows. 1, 2, 1, 2, 3. The other one is a small bone that sits on this bone. It's not shown here. Okay, then we have 1, 2, 3, and another 4 bone that cannot be seen from the anterior end. Then from the carpus, we go to the hand. Okay, this is a hand now. Okay, so that's the hand. Most of the times when you say hand, people refer to the arm. So the arm only ends at the elbow. From the elbow to the wrist is the forearm. The wrist itself is a carpus. Then we have the hand. Then after the hand, we have now the phalanges or the digits. So the hand is also known as a metacarpus. The metacarpus is the hand. Then we have phalanges or digits. We have 5. Starting with the pollex. That is a pollex. Index finger, right? Then we have the middle finger here. Then we have the annularis finger and the auricularis finger. Index, middle, annularis, and auricularis. Annularis because this is a finger that is used for wearing rings. So that's where the name comes from. Auricularis, auricle means ear. So this is most of the finger that we use to clean our ears. That's where the name comes from. This is a pollex, right? So this is a upper arm. Now remember that there are 2 of them. There's a left and right upper limb. So this is a right upper limb. This is what we're going to focus on. So before we go any further, I would like us to know that the human skeleton has a total of 206 bones. So counting one by one, we are going to have 206 bones in the human body, including those small bones found in the ear, what we refer to as ossicles. All right. Now, teeth, the 32 teeth that adults are expected to have are not part of this numerical value. Therefore, teeth are not considered as part of the human skeleton. Of course, they're attached in the skeleton, that is the upper and lower jaw, but they are not part of this numerical calculation of total bones found in the body. All right. So essentially, teeth are not bone. The question remains, what are they? We can research more on that one. Now, out of these 206 bones, we find that 64 bones are allocated to the upper limbs. All right. So in each upper limb, the left limb will have 32 bones in total. The other one also 32. If you add them, will give us 64 bones. So much of the bones of the human skeleton are allocated to the limbs, upper limbs and lower limbs. Okay. So upper limbs are used for, manipulating things, writing, touching, cooking, mainly simply manipulation. Lower limbs are associated for mobility. Okay, needless to say, human beings like you and I, Homo sapiens, are the only erect mammals that we have on Earth. The rest usually walk on 4 legs, but us, we walk on 2 legs. So there has been a lot of evolvement that took place to sacrifice one of the 4 limbs for manipulation. Okay, and that's why you can't expect a human being to run as fast as those quadrupeds, animals with 4 limbs touching the floor. Okay, us, we are bipeds because we have 2 limbs which plant into the ground. We use them for mobility, running, walking, crawling, and so on and so forth. So these values must be there in your mind as you study the human skeleton. So I've essentially talked about the parts of the upper limb: scapula, clavicle, shoulder girdle, humerus forming the arm, ulna and radius forming the forearm. Carpal bones, there are 8 in total forming the carpus, metacarpals. Then finally we have phalanges. Metacarpals are 5 in total. Metacarpals are 5 in total, then about 17 or so phalanges, these digits. So these are 5. 1, 2, 3, 4, 5. Then here you count now. For the thumb, there are 2. 1, 2, making the phalanges. The rest is 3. 1, 2, 3. So if you add 3 multiplied by 4, 3 multiplied by 4, that comes to should be 12. If you add, that's 13, 14, then you add all these. 14 plus 5, that makes up bones of the hands. So 14 phalanges plus 5, that gives us 19. Then you add the kappa. So all of these values must be there at your fingertips in an event that you're asked in an exam. So we start, discussing the upper limb from the clavicle all the way down to the phalanges. This is a breakdown of the parts of the upper limb, okay, their divisions and joints. First of all, these are the bones that make up. And here we have the joints. Okay, so you can look at that in your own free time. So we're going to start with the clavicle, right? So I'll skip that. We'll come to it later on. Let's look at the clavicle, what we call the key. So clavicle is called key because of its appearance, this bone here. So I'll be using diagrams for explanation, then I expect you to read the notes in your free time. I hope that is a fair deal. So, clavicle, we have two of these bones, right? Let me show you the chest first. So this is the chest. That is a sternum. Then here we have ribs. Now, muscle is still there. This is a pectoralis muscle. Pectoralis minor, pectoralis major muscle. Now, they cover the ribs. So if you remove these muscles, you find the ribs. Now, this is a sternum. This is a clavicle. Here it is broken, but it makes the connection between the sternum and the limb. Okay. So the only thing that attaches the upper limb to the central part of the body is this small bone here. So it is a very important bone. So whatever weight you are lifting or pushing, that weight or force will be transmitted through these bones and then cross into this small bone and goes into the chest. All right. So this bone here, the scapula, has no joint with the rest of the body. It only forms this shoulder joint there. After that, there's no any other physical joint between the scapula and any other part of bone apart from the clavicle here. You see that joint? Then goes into the sternum. Okay, so if this bone breaks, you can't lift anything. Okay, because it's not possible to do so. So we'll start with that bone, the clavicle. Of course, I'll focus much on the bone itself than on the written stuff. That is your duty. Now, what is important first is to start with orienting ourselves. All right. So this bone has two surfaces. So you should be paying attention to the values I'll be mentioning. Clavicle has two surfaces. It has a superior surface. So we're looking at this bone from above. That's how it looks like. Look at its shape. It is S-shaped. Apart from the superior surface, the clavicle has an inferior surface. This is the underneath. So the surface below this is the inferior surface. How do you know that this is superior, this is inferior? Literature says, even in examination anyway, in examining the bones, you find that the superior surface of the clavicle is smooth. It has less markings on it. So there are no ridges, there are no perforations, and so on. Whereas if you examine the undersurface, you find a lot of ridges. For example, you find a groove. So this is a depression. Another depression here is found, and another ridge here. So groove, depression, ridge. These markings are not found on the superior surface. Superior surface is smooth. That being said, it has two surfaces. Next is that it has two ends. So it has a lateral end and a medial end. Now, because the medial end attaches to the sternum and the lateral end attaches to the scapula, so it will carry those names of the structures it is associated with. So this part here that you are seeing is called the medial end. Since it goes to the sternum, we call it also as a sternal end. Then this part goes to the scapula. Now, on the scapula, there's a small bone called acromion process. So it makes a joint with this bone. So that's why it gets the name from. So this is a acromion end. Or if you like, you can just say the scapular end or the lateral end. Two ends, sternal, which is medial, acromio, lateral. Surfaces, superior surface, inferior surface. Superior surface, smooth. Inferior surface, roughened, or it has a lot of marking. An impression, a groove, and a ridge. Right. So that's all. Now, if you observe this bone, you see that it's not straight. The bone is more like S-shaped. All right. So the medial end, this part from here to there, projects forward in a living skeleton. So at any given time, you find that part pushing forward. All right. Let me take you back so that we can appreciate this. All right. So we're talking about this part here. So this part pushes forward. So it has a forward projection. All right. Whereas the lateral end projects backwards. So that's backward curve, frontward curve, anterior curve, posterior curve. That's how you can know them, apart from seeing that this is a sternal end, this is a acromial end. In addition to that, the sternal end has more like 4 corners, even though he is appearing roundish or oval. In true sense, when you're looking at the actual bone, this part is more thicker than this one. This is flat. The acromial end is flat, whereas the sternal end is roundish and with 4 corners. Away from that, this bone is special in that it is the first long bone. It is a long bone, by the way. Remember that long bones have epiphyses, and the diaphysis in between. All right, long bones should appear like this. Just a minute. So I'll refer you to the previous discussion we had about bones. So long bones have epiphysis. This is epiphysis. Then the shaft is the diaphysis. So the arrangement is the same. A scapula is also a long bone. Remember, long bone, we call them long bone not because of the length. It's because of those 3 features I've mentioned. 2 epiphyses, one here, the other one here, and the shaft in between. Now, what makes the scapula a special? What makes the clavicle a special long bone? Number one is that all long bones in the human body develop from cartilage. So they were cartilages before, and then they were transformed into bone when calcium begins to be deposited in there, and then new cells enter the cartilage, cells called osteoblasts, and begin the process of osteogenesis. Now, this long bone called clavicle does not develop from that. Instead, it develops from membrane, process known as, intramembranous ossification. So they all long bones in the body develop from endochondral ossification, except this one. So that makes it special. And that's why we find that in certain human beings, they are born without a clavicle. Okay. Condition known as cleidodysostosis. Cleidodysostosis. I think I have that, terminology somewhere, if I haven't forgotten. Anyway, cleidodysostosis. Absence of clavicle. Absence or underdeveloped clavicle. This is what is happening here. Number 2, all long bones in the human body lie vertical. They are always in vertical orientation. Look at this. Top to bottom, top to bottom, top to bottom, top. Even these are long bones, even though they are short. These are long bones. Fingers are made up of long bones because they have epiphysis, and the diaphysis in between. Now, All of them are vertical, but this one lies horizontal. Look at that. Instead of facing downwards, it is facing lateral, left to right. This is up to bottom. So that's, feature number 2 of a clavicle. Develops from membrane, which is intramembranous ossification. Number 2, it's the only long bone in the human body that lies horizontal. Number 3, the clavicle is the first long bone in the human body to fully ossify, to be fully transformed into a solid bone. Before these bones are completely transformed from cartilage into bone, this one is already formed into a bone. So by the time the baby is about to be born, this bone is already hard as compared to this. These are still cartilaginous. The central part is bone, but the rest is cartilage. But this one is almost completely bone. Maybe on the smaller parts, the lateral ends can have cartilage, but the whole lot of it will be bone. And therefore, during birth, it's easy to fracture the clavicle. Anything that is hard, you apply pressure there, it breaks. Cartilage is more flexible than bone, and therefore cartilage doesn't easily break. All right? When a baby is born, their bones are soft. You can bend them without breaking them, but not the clavicle. Why? Because at that moment in time, much of it is already transformed into bone and can easily break. And it usually breaks if labor is not conducted well. Fracture of the clavicle. So a baby is born with a fractured clavicle. Like, for instance, here, it breaks apart. It will mend anyway, but you should know that. That was feature number 3. It is the first long bone to fully ossify. What I mean by that is to be fully transformed into a bone. It was a membrane, now it has been transformed into bone. Okay, so I'll end there. There are so many of them, about 7 or so features, but those are the most important ones. All right. Now, what joints do we expect the clavicle to make? So the clavicle makes 2 joints. The clavicle makes 2 joints. I'll take you to the actual diagram. Clavicle makes 2 joints. One with a sternum, one with the scapula. So let's start with the sternum one. So we'll call that here. You see that joint there? So this is the clavicle, this is the sternum. So here it's easy to make up the name of this joint. This is sternum, this is clavicle. So it's called the sternoclavicular joint. This joint here is sternum, clavicular, clavicle. Sternoclavicular joint. What of the joint that will be made between the clavicle and the scapula? All right. Now, when it comes to the scapula, the clavicle makes a joint with the part of the scapula known as acromion process. This one here. That's the acromion process. Let me show you nicely. I need a good picture of the scapula. That's the bone I'm going to talk about next. It's a scapula. So this is a acromion process. This thing here is a acromion process, and it has a small depression where the clavicle will come and fit in. The scapula also has a small projection, this one called coracoid process, right? So the clavicle will come and lock here to make another joint. So this part of the scapula is called acromion. And then what is fitting there is the clavicle. So the joint is known as acromioclavicular joint. Acromioclavicular joint. Acromio from acromion process. Clavicular from the clavicle. Acromioclavicular joint. 2 joints I've mentioned. Sternoclavicular and acromioclavicular joint. Very important joint because it's the only joint that will connect the arm here to the clavicle. There is no joint here to connect the scapula to the skeleton. all right? The only way the arm will be connected to the rest of the skeleton is through a small bone called the clavicle, this bone here. And that's why if you are a starter in the gym, and then you find your colleagues lifting very heavy, kilograms of weights, and then you try to follow suit when you haven't reached, we haven't developed enough muscles to carry such weight, you find that you fracture your clavicle here. It breaks. Okay, some individuals even break their ribs because muscles will not stop contracting, right? Now, too much pressure on the bones, your muscles will break the bones. And you also tear your own muscles, tendons and so on. Ligaments will be torn as well. That's why it's important that you go slowly to develop the joints, develop the muscles, the tendons, all those should be given enough time to develop. You can't just start lifting 50 kilograms and 100 plus kilograms on the first week. That's too much. So that's about the clavicle, more like a key here. All right. Now the clavicle, when it comes to forensic anatomy, the clavicle can be used to identify the gender or the sex of an individual or the sex of the skeleton just by examining it. Number one is size. So we follow size. Number two, we follow markings. Remember, we said on the under surface or inferior surface, there are so many markings, all right? You find this impression, you find the groove, you find the ridges. In females, whether old or young, the bones of females have less markings on their surface. They have less features. That is simple because the human body of females has less muscle mass. The amount of muscle or the size, the bulk is less compared to males. So muscle growth is influenced by hormone testosterone. And therefore, muscle growth in males is higher than in females. And because muscles pull on bones, muscles act on bone anyway. So they create these markings. As a result, you find that bones of a male have clear markings, more markings, if I can put it that way, than female. So a skeleton of a female, to a lesser extent, will look like the skeleton of a young person. Why? Because of what I've explained. Females have less muscle mass. Unless this female has been working out in the gym, they are weight lifters and they are athletes and so on, then you expect those changes. As a result, this can be used to identify gender. For example, individuals have been involved in a traffic accident where they are bent beyond recognition. You can use this to identify which ones are male, which ones are female. Quite easier to do. Let's look at another bone of the upper limb, specifically the clavicle, the scapula. Now, scapula has the following: two surfaces, 3 borders, and 3 angles, right? So I'll focus on that. 2 surfaces. Okay, I want you to follow me. So this picture is showing the scapula from the front. So we're looking at the scapula from the anterior view. This is a person standing and facing you. This is how the scapula will look like. Next picture is showing us a scapula from the posterior view. So you're looking at this person from the back. Same scapula. It is the right scapula, by the way. But you are viewing it from posterior. Here you are viewing it from anterior. Now, so those are the 2 surfaces. So it has anterior surface, which is the one I'm looking at here, and also posterior surface. Now, you can already see the difference. Look at the anterior surface. It has a very nice wide area. But if you look at the posterior surface, it is wide, of course, but it has this spine. You see this? So we call this as a spine of the scapula. This is a spine of the scapula. Therefore, dividing this wide area into 2 parts. There's a part above the spine and the part below the spine. We'll come to that. So we'll leave it here for now. So this is a posterior surface. Some books will say dorsal. Remember, dorsal and posterior are one and the same. Then this is anterior, or you can say ventral surface. Now, the ventral or anterior surface is also known as a costal surface because this is a surface that faces the ribs. Let me take you back. So ribs will be near to this structure here. Let's go to that structure where we have a fracture. Here. So the scapula is there. Ribs are here, hidden under the muscle. So this part, the anterior part of the scapula, faces the ribs. That's why it's called the costal surface. Costal, meaning ribs. So those are two surfaces. Now let's look at the borders. So we're saying we have three borders. Three borders. So look at, it's easier to identify those borders if you're looking at it from the front for easy orientation. So border number one is superior border. You see that line here. Everything here is superior. So we call this as a superior border. Next is the medial border. A border that is now closer or facing the spine. This is a medial border. Then this side, we have the lateral border. You see this line? Lateral border. So three borders. Superior border or upper border, if you like. Medial border, closer to the spine or facing the spine. Lateral border, facing away from the body. Lateral border. Medial, facing towards the body. So we have mentioned two surfaces. We have mentioned three borders. Now let's look at the angles. Scapula has three angles. Number one is inferior angle. That's the inferior angle. Now, inferior angle is important, especially if you are trying to do lumbar puncture, so on and so forth. At this level, in a human being, when you're standing, there's nothing, you're not lifting anything. You're not lifting your arm. You just put your arm in a natural or neutral position. If you draw a straight line from the inferior angle, like this, you go towards the spine. The spine will be here. You are touching directly the 7th thoracic vertebra. The bone at the back there, called thoracic vertebrae number 7, is in the same plane with the inferior angle. So you can count from there now. So if it will be 7 here, meaning the bone below it will be 8, 9, 10, all the way to 12, since there are 12 thoracic vertebrae. So that's the importance. And I can ask you this question in your exam. Inferior angle is in relation to the 7th thoracic vertebrae. Correct. You get all the 2 marks or 1 mark. So this is inferior angle. Now let's look at if there's inferior angle, then there must be superior angle. So this is superior angle there. Superior angle. Right? Then finally, we have the lateral angle. Right here. Lateral angle. So 3 angles. You see this line that then bends. That's an angle. Look at this line and then bends like this. So angle, another angle here. Angle, bends. 3 angles, 3 borders and 2 surfaces. That's all. What is important is to know the names. Surfaces, we have anterior, posterior surface. Borders, we have medial border, lateral border, superior border. Angles, superior angle, inferior angle, and lateral angle. Now, in addition to that, let's look at the features of the scapula. So we have these 3 sharp bones, the 2 sharp bones, I beg your pardon. You see this one and this one? Let's see at them from the back. We're talking about this and that. So these are given names. The one that lies superior, look at that, this is inferior. So the one that is superior is also posterior. Check it out. This is posterior, this is in front. So the inferior one, apart from being inferior, it is anterior at the same time. The superior one, apart from being superior, it is posterior. It's at the back. So this one will be in front, this will be at the back. So let's begin with the one that is superior. So we call the one that is superior as acromion process. Acromion process because it is a projection. So all bony projections are called processes. Acromion process, right? It is posterior and superior to the coracoid process now. So this is coracoid. Look at that spelling. Coracoid. So coracoid is anterior but inferior to the acromion process. Immediately inferior to the coracoid process is a small depression there. I want us to look at this depression clearly. We call it the glenoid cavity or glenoid fossa. This one here. So we have turned the bone. We are looking at this cavity here. That cavity there. That cavity there. Now, we'll turn this bone and look at it from this side. Direct, putting our eye in this cavity, which is here now. This is a glenoid cavity. You can see that it is wide and well-shaped. It has a depression, meaning there must be a bone that will come and fit here. And that bone is called the head of the humerus to form a very important joint known as shoulder joint. Anatomically, we call that joint as glenohumeral joint. Gleno from glenoid cavity, humeral from the humerus, the bone that fits there. Glenohumeral joint, or layman's term, you call it glenoid cavity. Very important, even though it is one of the most unstable joint, but it's essential for locomotion, you know, manipulation of things by our hands. And the kind of motion that occurs here is what we call circumduction. Movement of the limb in all directions occurs here, circumduction. So that's a glenoid cavity. Glenoid cavity here. So we have mentioned the following structures: acromion process, coracoid process, glenoid cavity, where the shoulder joint forms, glenohumeral joint. Now, when you turn the scapula and look at it from the back or the posterior end, this is anterior, this is posterior. You see this spine. Now, we are giving it a name. So this is a spine of the scapula, or the spinous process of the scapula, if you want. Spine of the scapula. Now, the spine of the scapula divides the posterior surface into two surfaces. There's a superior surface there and the inferior surface. So these surfaces are not flat. They are more like depressions. So we call them as fossa. So that's a fossa and that's a fossa. The superior one is smaller. The inferior one is larger. So because the superior one is above the spine of the scapula, it carries that name, supraspinous fossa. Supra means above. The inferior one is below the spine, so it will carry that name as well, infraspinous fossa. This is supraspinous fossa. This is infra. Infra meaning inferior to the spine. So at the back of the scapula, there are two fossa, a supraspinous fossa and infraspinous fossa. Now, I mentioned why the inferior angle is important, because it lies on the same plane with the 7th thoracic vertebrae. Now, what about the origin of the spine? So here, where the spine of the scapula begins from, lies on the same level as the 3rd thoracic vertebra. So here, if you draw a line straight, this is where the spine will be, because we're looking at the scapula from the back. It's at the same level with the 3rd thoracic vertebrae. And I'm emphasizing, you mark those numerical values I'm mentioning. Inferior angle is at the same plane with 7 thoracic vertebrae, whereas the origin of the spine of the scapula, which is here, is at the same level with the 3rd thoracic vertebrae. Very important to know. So those are the features of the scapula that I've mentioned, right? And it's important that you revise them. that's about the scapula, right? Very important because it enables the arm to be connected to the clavicle, and therefore the clavicle serving as a point of connection between the arm and the rest of the human skeleton. So we have talked about two bones, the clavicle and the scapula. Now let's talk about the humerus, right? And obviously we'll end here for today. Humerus, this is a bone we are looking at. So now humerus is the only bone that makes up the arm. So the arm only has one bone. I explained divisions of the upper limb. There's arm, forearm, wrist, hand, and so on. So we're talking about the arm, right? We only find one bone. So this is similar to the femur in the lower limb. The thigh, in the thigh there, we only have one bone. There are not two bones. It's one large bone and a very long bone. Similarly, in the arm, there's one large bone, and it's quite long as well. So this bone has a proximal part. This is proximal. This bone has a distal part. This is distal. Then this is a shaft, or what you can call the diaphysis. So this is epiphysis. This is diaphysis. So now you're looking at the bone from the front. Then here, we are still looking at the bone from the front. I want to have a posterior view. Yeah, this is, now we're looking at the bone from the back. So this is posterior view. You can see this. This is a distal part. If you look at the distal part, the posterior part of the distal part only has one cavity there. Check out the anterior one. See, anterior has two. 1, 2. Anterior has 1 and 2. So the moment you see in the distal part that there are two fossa, then you're looking at the bone from the front. If you see that there's only one big fossa, like that, then you're looking at the bone from the back. So we call this fossa as olecranon. Olecranon fossa. The label is there. Olecranon fossa. So we use this fossa to orient the bone, to know whether you're looking at the bone from the front or from the left, from the back, sorry. Now, let's begin with the proximal part and see which parts are there. So the proximal part of the humerus has the following features. Number one is the head. This is the head of the humerus. Did I say femur? This is humerus. I beg your pardon. The proximal part of the humerus has the following features. Number one is head. Right? So most long bones have head and neck. So this is the head. Now, see that the head looks like a bow. And this bow must fit in a certain socket. And that socket is what we identified on the shoulder or the scapula. This is a socket where the bow or the head of the humerus will fit in. We call this as a glenoid cavity or glenoid fossa. So that's a head. Humerus has head. That's a head. Now, if a humerus has a head, then there must be a neck somewhere. You can't have a head without a neck. So this is a neck. Now, the problem is that the humerus has two necks. It has an anatomical neck, which is a true neck, and also has a surgical neck. Look at that. So let's start with the anatomical neck. The anatomical neck attaches the head to the rest of the body, of the bone, sorry. Head, then this is the entire bone. So that area there, that line, is what you refer to as a anatomical neck. The real neck of the humerus. Now, you see that this part here is very wide. Then the bone begins to become narrow here. And then goes on to be like that. So this part where the bone begins to become narrow is what we refer to as the surgical neck. You see that line there? Surgical neck. Why is it named so? Anyway, because when the bone is developing, ossification begins here. It was a cartilage, now it has to be transformed into bone. So that transformation begins here at 8 weeks, then spreading out in that direction and this direction. So here, transformed into bone, The next part to be transformed into bone is this one until it goes all the way like that. Now, when the baby is born, another ossification center appears there. So the two should meet. Here, bone is developing, replacing cartilage. This side, there is cartilage, also being replaced by bone. So the two processes will meet here along the way. So this area where they meet is weak because the two areas, this one and this one, the epiphysis and diaphysis will completely meet there and somewhere here at around 25 years of age, right? So in younger persons, teenagers, pre-teenagers, toddlers, and so on, this part is very weak. Now, if a child falls on their arm like that, they easily develop fractures in this area. The bone cuts off clean because that part is very weak. So it has been termed as the surgical neck because the way the bone cuts is like someone cut through using a very sharp instrument when actually it's just that's a weakness in the bone. So that's why it's referred to as surgical neck. The actual neck is anatomical. This one here, anatomical neck. So you don't have to forget those important facts. Surgical neck here, anatomical neck there, the real neck. Now, if you're looking at this bone from the front, you see two swellings. There's one here and this one. So this one is bigger and a bit superior. This one is smaller and a bit inferior. So these are known as tubercles. So the humerus has two tubercles in the proximal area. So it has a greater tubercle and a lesser tubercle. Similar to the humerus, to the femur, sorry. The femur has trochanters, greater trochanter, lesser trochanter. Similar in structure, but they are bigger in the femur. So here we call them tubercles instead of trochanters. So that is a greater tubercle. This is a lesser tubercle. Now, I want you to observe the following. The greater tubercle faces in the opposite direction to the head of the humerus. The head of the humerus is facing medial towards the body, whereas the greater tubercle faces lateral or away from the body. And this position is permanent. All right. So when you hold the bone like this, or at any given time, the head of the humerus should face medially. Number two, these two holes should face anterior. Then you have held the bone in its rightful position. And it's easy to describe it to the next person like that. So keep in mind to say the greater tubercle is lateral, whereas the head is medial. If you turn them the other way around, then you are going to be looking at the bone from the back because you have turned the bone like this. See now, the head is facing lateral, the greater tubercle is facing medial, but we don't have such a skeleton where the arm faces backwards, unless there's a serious disorder that causes the arm to fail to rotate during development. Otherwise, in a normal position, the arm should be held like this, okay, so that the arm faces forward. So those are the features I've mentioned: head, anatomical neck, surgical neck, here where it becomes narrow, greater tubercle, lesser tubercle. Now, if you observe between the greater tubercle and lesser tubercle, there's a small depression there, more like a tunnel, all right? Now, this tunnel is called the sulcus, or groove, if you like. You can use either of those words, sulcus or groove. The first word describes where the groove position is. This groove is in between two tubercles, greater tubercle and lesser tubercle. So it's called inter. Inter means in between, or between two or more entities. So it's called intertubercular because these are tubercle, greater tubercle, lesser tubercle. So it's an intertubercular sulcus or groove. You decide which one to use. None of them will be marked wrong. They are both correct. So that's the intertubercular groove. There. Intertubercular groove. Now, if you follow this groove, you see that you're going into the shaft, right? Now, within the shaft, there's an important feature that we must talk about. It's called the deltoid tuberosity. Observe the nomenclature here. Tuberosity is different from tubercle. So I don't want you to mix these terminologies. Now, the deltoid tuberosity is always in the same position with the greater tubercle. They are both lateral, lateral, lateral. You see that? So at no point are you going to find this deltoid tuberosity in the medial side. It's not possible because the deltoid muscle covers the shoulder here. This is a muscle that you inject babies into when you're giving them some intramuscular drug injection, even adults to some extent, because it's a very, bulky muscles, and you can easily give intramuscular injection there. So there's a deltoid muscle there covering the whole shoulder, right? Now, the muscle will cover that part and then come on the end here. It attaches there. So the muscle pulls the limb away. So when you're doing like this, it's a deltoid muscle that is pulling. Here, it's like a rope pulling out. So that's the deltoid tuberosity there for attachment of deltoid muscle. Very important feature that you must mention. So in an event that we bring this bone in your test and ask you to label it, you must be able to label all these features we are talking about. All right. There are so many other features, but I'm focusing on the most important ones. These others you can read on your own, but really the important ones we must discuss. So that's about features in the proximal part. It's head, neck, surgical neck, two tubercles, and the intertubercular groove. Then in the shaft, we just talked about one feature, which is the deltoid tuberosity. What about in the distal part? Let's quickly examine the distal parts. So this part here is proximal, but the name is the same. This is epiphysis, whereas this is also epiphysis. So you have the proximal epiphysis and the distal epiphysis, right? Now, what do we find in the distal epiphysis? What features are important? Number one, you see these small depressions. They are facing anterior, right? Okay, so one faces lateral. This is lateral, remember? In line with the greater tubercle, in line with the deltoid tuberosity, in line with the radial fossa. Now, if you hold your arm like that, you find that your thumb in natural position, when your palm is facing forward, your thumb faces lateral. Your thumb should look lateral. Then your little finger should be medial. Because in our natural position, the palm should face forward. If you remember anatomical position, the palm is facing forward and the fingers are together. So the line where the thumb is, that's where you find the radial bone. So in the forearm, there will be two bones here. One bone will be lateral, which is the radius. One bone will be medial, which will be the ulnar. So the radial bone locks here when you put your arm like this. There. The two bones lock each other and they fit in here. So what fits in there is the radial bone. Okay, so we call that as the radial fossa. Radial fossa, because of the bone that goes there. So this radial fossa is always lateral, like this, if you're looking at the bone from the front. Then neighbor to it is a coronoid fossa. Coronoid fossa. All right. Now, the coronoid fossa on the ulnar bone. Remember, the ulnar bone will be medial. On the ulnar bone, there is a very large bone, a projection that locks in here. Let me show you that one quickly. This thing here, that's a coronoid process. Coronoid process of the ulnar bone. Yeah, coronoid process of the ulnar bone. Where's the ulnar bone? Yeah, this is the ulnar bone. This is a coronoid process of the ulnar bone. It's the one that locks in the coronoid fossa. Like there, yeah. So it locks here. So this depression is created by that projection I've shown you. Otherwise, the bone would have been flat here. But because we move our hand like that, so constant pressure there creates this fossa as we grow up. All right. So that's why your arm cannot go beyond this angle. It's not possible because the bones have locked each other there. So what goes in there is a radial bone. What goes there is a coronoid process of the ulna and locks the elbow in that position. Okay. So two fossa I've explained. Radial fossa, lateral, coronoid fossa, medial. Apart from that, if you see that in the lateral side, there are these swellings, right? So we call these as epicondyles. So there's a lateral epicondyle because it is facing away from the body. There's also medial epicondyle because it is facing towards the body. Epicondyles, lateral and medial epicondyle. Now, if you follow the epicondyle back into the shaft, you see there are these more like flattened parts, like wings, like this. So we call these as supracondyles. Supracondyle, supracondyle. So there's the medial supracondyle and lateral supracondyle. So don't mix the two. Epicondyles are these sharpened points, whereas supracondyles are these more like wings above. So we have supracondyles and the epicondyles. You just have to know which one is medial, which one is lateral, and give them that name. So we have medial epicondyle with its medial supracondyle. Lateral epicondyle with its lateral supracondyle. Now, immediately inferior to these two fossa that we talked about, the coronoid fossa and radial fossa, we have these two swellings. We have a capitrum and a trochlea. So capitrum is lateral. Trochlea is medial. Capitrum and trochlea. Now, the trochlea goes all the way to the back. Let me show you that. So this will be capitrum, then this is trochlea. Now, see from the back. This is trochlea. The capitrum ends there, so it's not seeing much from the back. Now, the capitrum sits in a fossa created by the ulna. So it forms a hinge joint. You know, a hinge is what holds the door into the door frame. So at any given time, the normal door that you and I know can only swing in two directions. Either it's opening or closing. There's no way that the door will move up and down. It's not possible because we don't have such kind of a connection. So that movement is hinge. Open, close. All right. So that's why there are only two movements here at the elbow. It's either straightening the elbow or flexing the elbow. Like that. So that is hinge movement. So the kind of joint that is there, we call it hinge joint. Now, let's see how that joint is created. All right. You see this. This is the ulnar bone. The ulnar bone goes like that. And then the humerus we're discussing sits there. So the only movement that will occur here is this bone to lift and go there or go back. So the movement is hinge in motion. Goes like that, back, hinge. So the capitrum is this one. Whereas this is the, sorry, this is the trochlea. I beg your pardon. This is the trochlea. Okay, then this is a trochlea fossa, where the trochlea will sit in. So this is the ulnar bone. This is the radius bone. The bone is broken here, but we are looking at the joint. So this joint is a hinge joint. Hinge joint. Only two movements are expected: flexion and extension. Nothing else. There's no lateral movement or whatsoever. So the joint is kept stable like that. So this is a capitrum. We are talking the trochlea. Sorry, that's a trochlea. We are now looking at the bone from the back. Let me take you back again. Here. This is a trochlea, capitrum. Now, we're looking at the bone from the back. That's a trochlea. That's a capitrum. So capitrum doesn't go much. Now, the trachea begins anterior. Let me show you again. Trachea begins anterior from the coronoid fossa and then goes all the way at the back into the olecranon fossa. This is the olecranon fossa. And I was saying this fossa is found at the back of the bone. Of course, a distal end, but at the back. Now, I'll show you which bone fits there or what bone creates this depression. It is the ulna with its olecranon process here. This is the olecranon process of the ulna. So it will come and lock there and creates the olecranon fossa. This is a coronoid process of the ulna. It fits there and forms a coronoid fossa, which I've explained. Okay. Coronoid fossa is here. That's a coronoid fossa. You follow the trachea at the back. You find the olecranon fossa. Olecranon fossa. And that's a trachea that sits in the trachea fossa of the ulna, this one here, and forms a hinge joint. So this will lock there so that you don't overextend your arm. Otherwise, if it doesn't lock here, this arm will move at the back like that and fold. That would create serious problems for your arm. Equally, in front, you can't move beyond this because this bone will lock here. So that's how important these structures are, so that the joints are stable. So those are the features of the humerus. We talked about proximal features, features in the shaft, and features in the distal part of the bone. Now, as I close off, I would like you to do one experiment. Now, this is a bone, so you're looking at the bone from the front, right? Now, this is a medial epicondyle. So where you are, simply identify the medial epicondyle, all right? So if you raise your arm like this, you see this sharp bone, not the tip, because the tip is the olecranon process. There's this tip of the bone inside there, all right? If you run your finger underneath that bone and you hold or press very much, you are pressing on a nerve, a very important nerve called ulnar nerve, all right? So the ulnar nerve passes underneath the medial epicondyle, this pressure here. So this is where you want to touch. You put your finger down there. You press very hard, you feel numbness in your arm, or you feel some tingling sensation. Or if you move your finger left to right, you feel like there's a rope that is moving. That is the ulnar nerve. If you, by any chance, there's fracture or there's a cut so deep that it punctures or cuts that nerve, then you paralyze some of the muscles in your arm and your palm. All these will be knocked out. The little finger and the annularis finger, the ring finger. You fail to move them, they'll become paralyzed because you have damaged the nerve that controls muscles that move those fingers, ulnar nerve. So this part here is called the groove for ulnar nerve because it's a nerve that passes there and creates that depression. So I hope you are able to identify that on yourself. That being said, we'll end today's discussion about upper limb here. The next discussion will finish up the upper limb. So send the notes, make sure that you go through, and where necessary, you raise questions or clarifications. You can contact me. I'll still be able to explain.